Molecular imaging allows us to visualize cellular and physiological behavior inside the body. Traditionally, this process relies on injecting radioactive isotopes and tracking the volatile energy released during their spontaneous decay. The challenge is acquiring that same cellular data without exposing the patient to ionizing radiation. We can achieve this through two distinctly different physical pathways. The first relies on mechanics, specifically the behavior of high-frequency sound waves. The second relies on optics, capturing visible light emissions at a microscopic scale. Because we are no longer tracking radioactive decay, we have to engineer contrast against the background tissue by altering the physical environment itself. Two primary modalities accomplish this: contrast-enhanced ultrasound and optical imaging. Mastering non-nuclear imaging requires abandoning radioactive materials in favor of engineering precise physical boundaries, forcing either massive acoustic reflection or visible photon emission. Contrast-enhanced ultrasound, or CEUS, replaces standard fluid contrast with the injection of highly engineered microbubbles. To build a microbubble, we start with an outer architecture. This is a fragile lipid shell, measuring precisely between 1 to 4 micrometers in diameter. Inside that shell, we trap a core of heavy gas, typically high molecular weight perfluorocarbons or sulfur hexafluoride. This specific construction exploits a bedrock physics concept known as acoustic impedance mismatch. There is an extreme density difference between that internal gas core and the surrounding blood and tissue. When an incoming ultrasound wave hits that boundary, the sudden drop in density causes the sound wave to violently reflect backward. The surrounding blood mostly passes the wave through, returning almost zero signal. The microbubbles, however, are highly echogenic, creating a bright, unmistakable return signal. These structures are inherently unstable. They circulate for only a few minutes before the mechanical force of the ultrasound waves breaks them apart, or the reticuloendothelial system clears them out entirely. CEUS generates its signal not by emitting emittergy, but by weaponizing density to aggressively reflect acoustic waves. A standard microbubble injection only maps bulk blood flow and perfusion. To turn CEUS into a true molecular imaging tool, we modify the outer shell by adding specific ligands. These ligands are engineered to bind to precise disease markers. For example, we can attach ligands that seek out VEGF, a marker for angiogenesis, or ICAM1, a marker for inflammation. As the bubble circulates, the ligand physically locks onto the target receptor, anchoring the microbubble to the site of the disease. But the architecture of the microbubble introduces a strict limitation: its physical scale. At 1 to 4 micrometers across, the bubble is massive compared to the tiny gaps between endothelial cells. It physically cannot cross the vessel wall to reach deeper tissue targets. The technique is further constrained by the ultrasound hardware itself, which restricts scanning to small, localized areas and makes the quality of the image highly dependent on the operator's skill. Targeted CEUS delivers immediate, real-time molecular data, but its physical bulk permanently confines it to the interior of the bloodstream. If acoustic reflection is bottlenecked by physical size, we must turn to the photonic mechanism, optical imaging. Here, the signal is generated entirely by detecting visible photons. The first optical technique is bioluminescence, which relies on a purely biochemical process. This process requires two components. The first is an enzyme called luciferin, which is typically found within specific target cells, like tumor cells. The second component is introduced externally. We inject a substrate called luciferin into the system. When the injected luciferin enters a cell and meets the resting luciferin enzyme, it triggers a rapid chemical reaction. The direct byproduct of this specific enzymatic reaction is the ejection of a detectable, visible photon. Because this reaction only happens where the enzyme is present, bioluminescence offers pinpoint accuracy for locating tumor cells and continuously monitoring their response to therapy. Bioluminescence effectively turns the target cells into their own light source, converting internal biology directly into a visible signal. The second optical method is fluorescence. Unlike the biochemical reaction of bioluminescence, fluorescence is entirely photophysical. We begin by injecting a specialized molecule. Then, an external light source of a specific wavelength hits the target molecule. The incoming energy forces the molecule's electrons to shift outward. pushing the molecule into an unstable, excited state. It cannot maintain this energy. As the molecule inevitably snaps back to its ground state, it sheds that excess energy by releasing a visible photon. The primary advantage of fluorescence over bioluminescence is that these molecules can be repeatedly excited, allowing us to generate a continuous signal. However, both fluorescence and bioluminescence suffer from a severe physical bottleneck: tissue depth. Unlike the high-energy X-rays or gamma rays used in nuclear imaging, visible photons have extremely low penetrating power. As these photons attempt to exit the body, they bounce off cellular structures, scattering in random directions and losing energy until they attenuate completely. This severe background signal loss restricts optical imaging almost entirely to superficial structures. Optical imaging maps cellular activity with high specificity, but the data is lost the moment the target dives deeper beneath the tissue surface. Engineering a signal without nuclear isotopes requires leveraging strict physical boundaries to generate contrast. Contrast-enhanced ultrasound forces massive acoustic reflection, but its physical scale traps it inside a vascular cage. Optical imaging achieves precise photon emission, but the weakness of visible light leaves it vulnerable to depth and scatter. This table summarizes the relationship between the three modalities. The physical mechanism used to generate the signal, whether acoustic impedance, biochemistry, or photophysics, directly dictates its primary clinical limitation. Mastering non-nuclear imaging demands an understanding of how the machine detects a signal, and an exact accounting of the anatomical and physical barriers that stop the signal in its tracks.